This is a scan where a small amount of iodine that has a nuclear isotope attached to it or labeled with a nuclear isotope is given to the patient. And because the thyroid gland traps iodine, we then can take a picture of the distribution of iodine within the thyroid gland. So the top left is a normal gland where iodine is accumulating in the thyroid gland, the right and the left lobe, and it's in a sort of normal uptake or normal concentration. And in somebody in Graves' disease, that uptake is very much increased. So no other cause of hyperthyroidism causes this form of pattern on an uptake scan. And then it helps us distinguish the hyperthyroidism from other conditions. For example, this is a person who has a couple of nodules or growths, two on the right and one on the left, that's causing hyperthyroidism because these are little tumors. They're usually almost never cancerous, but they're nevertheless the driving force for the hyperthyroidism. And this is a person who has a single nodule, a single hot nodule that's causing an overactive thyroid gland. So sometimes we need to do this scan, especially if the antibody testing does not help us. But if somebody has hyperthyroidism and has a positive thyroid stimulating immunoglobulin, that's Graves' disease. Nothing else causes that. So this is a endocrinologist's view of thyroid eye disease. So it's a very, very introductory slide. You'll learn and hear more about this. But there's a couple of important points from an endocrine perspective that I'd like to make about the eye manifestations. Because certainly I'm not an expert by no means in the eye condition. The first point is that the thyroid part of Graves' disease and the eye part of Graves' disease typically come together temporally in the same time frame, usually within a year of the diagnosis of each other. But not always. Sometimes a person can have the thyroid condition and that could be treated and go into remission, and decades later will have an eye manifestation. And this is an important point. It happens enough that we all need to be aware of it. I can give you an example of a patient who I've been taking care of personally for about 15 years, but she's had Graves' disease for longer than that, and she's been off and on medications for Graves' disease and has always been doing fine, and her thyroid levels have been controlled, almost to the point that we've kind of forgotten, her doctors have forgotten that she even has a thyroid problem, because there are periods of time when her Graves is in remission after treatment, and she's fine, and the thyroid levels, all those numbers and letters, T3, T4, are all normal, and then all of a sudden she presented with a bulgy eye and an exophthalmos. And everybody was sort of, wondering, because her exophthalmos was asymmetric, meaning that one eye was more affected than the other. There was this whole worry that could this be a tumor, and so on and so forth. But the point is that this is the same condition, it's just that it showed itself at a different time. So although they typically come together, the two manifestations can happen at different time points in somebody's life. And in fact, there are people who have thyroid eye disease and have completely normal thyroid levels. They never were hyperthyroid to begin with. The immune system is the culprit, and the thyroid is a victim, and the eye is a victim. And every other place of the body is also a victim of the immune system. So having normal thyroid levels does not mean that you don't have Graves' disease. Ophthalmologists are very aware of this, that they know that a patient can have completely normal thyroid levels, and if the clinical manifestations of the eye disease is indicative of an autoimmune problem, then it's going to be thyroid eye disease. It is less common than the incidence of Graves' disease per se. Thankfully, although many people have some symptoms of the eye problem and the eye manifestations, depending on what you use to look for it, imaging studies will detect some form of eye abnormality in the majority of patients, but thankfully it's only a small percentage that are going to be life-threatening and require perhaps an emergent procedure or surgery because vision is threatened and we need to act quickly. So those are sort of general comments from a medical endocrine standpoint. The other important point that I'd like to make about the eye, and I think most of you already know this, although it is a hard concept to sort of accept, is that, but I think you accept it now because I've driven the point that this is an immune system problem, not a thyroid problem. But as a corollary to that, means that any treatment that your doctor gives you for the thyroid problem is not going to help your eye problem. In fact, some treatments that we'll talk about for the thyroid condition can worsen the eye condition. And so these are sort of parallel diseases. The treatment of one does not necessarily treat the other. Sometimes we see some exceptions to this rule, but just as having oculoplastic surgery on your eye is not going to treat the thyroid problem, right? Treating the thyroid problem is not necessarily going to help you with the eye disease. So this is why it requires a team, and it's important to have a collaborative interaction between the ophthalmologist, the internist, endocrinologist, thyroid surgeon to come up with the best treatment options. So we're getting close to the end here. So treatment options, really 3 treatment options: medications, radioactive iodine, and surgery. So these are the topics, and there's going to be a busy slide here. I'm going to warn you, so you can just tune that out and just maybe listen, and you can I think we can make these available for whoever wants it. That's okay. So the first thing that we want to do is first to make the patient comfortable, especially if they have significant heart symptoms, like the palpitations and the irregular heart rate. So the first treatment that we often give people are a class of medicines called beta blockers. And that's the first thing that's listed here. Beta blockers help regulate some of the symptoms of hyperthyroidism, the palpitations, the tremors, the restlessness. They're not treating the underlying problem, but they provide some comfort until other treatments begin to work. Okay, so we have lots of different beta blockers available. They all end in the letters OL, so propanolol, metoprolol, atenolol, and these are medicines that can be taken once, twice, or 3 times a day and help sort of calm some of the symptoms, put a Band-Aid on it until a more definitive treatment kicks in. Now, the most common treatment to treat the actual thyroid overactivity are a class of drugs called anti-thyroid medication. And in Europe, anti-thyroid medications are the #1 initial treatment for Graves' disease. In the United States, I think there is an increase in the use of anti-thyroid medication over the years, but perhaps worldwide, anti-thyroid medications are the most commonly used. These medications block the formation of new hormone, and they are fairly effective. They do take some time to work, though. So these medications are not something that you take, like the beta blocker, and the symptoms get better right away. They take about 4 to 6 weeks to kick in, and the reason is that they're inhibiting the formation of new hormone. The hormone that is already high in your bloodstream is already high. That needs to decay gradually through its half-life, which is 7 days. So it takes 4 half-lives, or about a month, for the T4 levels to gradually decline. So these medications, anti-thyroid medications, will take some time to achieve improvement in thyroid levels. And so that's why we bridge that gap with the beta blocker initially. There's 2, in the United States, there's 2 anti-thyroid medications. Metimizole is one of them. The other name for metimizole is Tapizole. And the second one is propylthiouracil, or PTU. The favored medicine is metimizole or Tapizole because it tends to have less liver side effects, but really Both of them are quite effective and safe. The risk of a serious adverse reaction like causing the bone marrow to shut down or causing liver abnormalities are pretty rare, as it says, like 1% or lower. But these are things that we need to monitor in people who take the anti-thyroid medication. The duration of treatment with anti-thyroid medication is generally going to be 18 to 24 months. And the expectation or the hope is that after about 1.5 to 2 years of treatment, that we will be able to hopefully induce a remission, and hopefully that remission will be long-standing. Unfortunately, that's not always the case. There are recurrences that can happen. This particular diagram cites about a 50% recurrence rate. That's an overall recurrence rate. I find that in individuals who have smaller thyroid glands and don't have such severe hyperthyroidism, the recurrence rate will be lower than that. But across the board, there's a 50% chance that even after successful therapy with anti-thyroid medication, that sometime down the road, the condition will recur. Okay, so we use the term remission, we don't use the term cure. Okay, in fact, there is no cure. Some people think, oh, I'll just take my thyroid out, I'll go see Dr. Larian, he'll remove my thyroid gland, cured. Nope, and remember, the thyroid was the victim, the immune system is the problem. So he can take out your thyroid gland, and that's perfect. In 20 years later, it's possible that you'll get the eye manifestation. You won't get the thyroid overactivity anymore, unless perhaps enough thyroid tissue is left behind that over time it will grow back. But assuming that a complete thyroidectomy was done, the overactive thyroid will never recur, but the other manifestations can happen. So again, the term is remission and control of thyroid levels is the goal of these medications. Radioactive iodine is another option, and really the way I look at radioactive iodine is that it changes one condition for another. It swaps hyperthyroidism for hypothyroidism. Generally, that's the end result that will happen as time elapses from radioactive iodine therapy. And so why would we do that? Well, it's easier to treat an underactive thyroid compared to an overactive thyroid. The replacement for an underactive thyroid is the same hormone that the body makes. It's a replacement. It's an identical replacement, whereas anti-thyroid medications are man-made foreign products that the body normally does not produce, does not make. So the replacement for an underactive thyroid is going to be safer than giving anti-thyroid medications with the risks that we talked about. Now, radioiodine takes some time to work. It's not an immediate fix. Oftentimes people who are treated with radioactive iodine will then need to go back on anti-thyroid medication for a short period of time until the effects of radioiodine are realized and the thyroid levels improve and ultimately will become underactive. Now, one important consideration for the purpose of today is that there is some data that in a person who has active thyroid eye disease, that radioactive iodine can worsen that eye disease. And so in this situation, there could be a deleterious or a negative effect of the treatment for the thyroid for the eye. And so in somebody who has active thyroid eye disease, radioiodine is best avoided, in my opinion, and although there's discussion in the medical community about that, but most of the time we try to avoid that in an active, symptomatic situation with the eye disease. Of course, radioactive iodine cannot be given in a woman who's pregnant or is contemplating pregnancy soon thereafter, so that's another important consideration for radioactive iodine. In the final treatment, thyroidectomy, now I've listed these in this sort of order, but that doesn't mean that this is the order that we go through. All of these treatments are discussed with the patient, and a decision is made with respecting the patient's wishes and their goals and where they are in life. And so it's quite possible that thyroidectomy may be the first option for a patient and not the other ones that I listed here. So again, thyroidectomy will restore or relieve the overactive thyroid situation, and it's pretty rapid. Once the thyroid gland is out, the thyroid levels then need to be replaced with a replacement, but you're not going to get the overactivity. Of course, it is important to first get the thyroid levels normal before somebody is sent to surgery, and that's because having hyperthyroidism makes that person a higher surgical risk. That you can't really safely put somebody under anesthesia if they have high levels of thyroid hormone. So if thyroidectomy is the option that is chosen, the thyroid levels first have to be brought to normal, and then the patient can go for surgery. So again, this is the important thing. This, as far as we know, this is not necessarily going to relieve the eye situation. It's not going to make it worse, but whether removing the thyroid actually helps the eye is controversial. And again, it's an important consideration, thyroidectomy in a young woman who's planning pregnancy or is pregnant. So the question was, radioactive iodine will assuredly worsen the eye disease in somebody who has active eye disease. In medicine, nothing is 100%, but I would say more likely than not, it's going to make it worse if it's an active situation. Now, so sometimes it doesn't, and so there are some precautions that can be taken to try to mitigate against that risk. So sometimes around the time of radioactive iodine, we may treat the patient with some steroids, and that could help reduce some of that risk. But I think the way that I would look at it is that it probably will worsen it. It's not guaranteed, and it's certainly not helpful. So why, so the first question I think is, why is it that radioactive iodine can potentially worsen the eye disease? And it's not known for sure, but when you give radioactive iodine, you're causing a destruction of the thyroid gland. And potentially that destruction and injury can release molecules that then the immune system can all of a sudden decide to feed on and sort of like boost the immunological process. And so as the thyroid gland is sort of dying off, it's sort of releasing everything and all sorts of molecules that may be part of the target that the immune system is attacking, it will then become further exacerbated. So that's a theory. Now with thyroidectomy, when you remove the thyroid gland, you actually remove all those targets for the immune system to attack. So it does have the potential, and in some studies does show a benefit on the eye course, but not in every study. Okay, so again, to summarize that, radioactive iodine could potentially worsen the eye disease, but certainly does not improve it. Thyroidectomy can, in some situations, based on what study you read, can improve the eye findings, but that is not a guaranteed process, and it certainly does not worsen it. The primary object has been removed, but the problem is that the thyroid and the eye, the structures behind the eye, share similar objects, and so the immune system can still, attack those. And so it can't attack the thyroid because it's not there anymore. And remember that the immune system also has memory. So just because you remove the thing that it was attacking, it still remembers and it's still on alert and producing these sort of autoantibodies. And the other, point worth mentioning is that when a person has an autoimmune disease like Graves' disease, they're actually at risk for other autoimmune diseases. Their immune system is dysregulated. The fact that it's attacking the thyroid, yes, that happens, but that person already has distinguished themselves as having a tendency towards autoimmunity, and the immune system can attack another part of the body, not the part of the immune system that is attacking the thyroid antigens, but other things in the body. I mean, for every part of your immune disease, if you have autoimmunity against your skin, it's called vitiligo. It could be psoriasis. If you have it against your hair, it's alopecia. So there's pancreas is diabetes. Yes, you could have a situation where the immune system is making an immunological reaction against the thyroid that is destructive and would therefore lead to Hashimoto's disease and hypothyroidism, but also antibodies that are stimulatory and would try to take you towards the side of Graves' disease. And so those could coexist, and you have this sort of tug of war, and whichever one is winning will drive you to that side of the thyroid condition, whether it's hypo or hyper. So yes, you could have autoimmune thyroid diseases, that's Hashimoto's and Graves' disease. Sometimes that's called hashitoxicosis. I mean, it has different names, but it's possible, but it's uncommon. Yeah, it could happen. The opposite is usually seen. So in Graves' disease, when you follow patients for a long, long time, about 10% of them will then end up hypothyroid. And we think that they've sort of, sometimes it's called their Graves' disease burnt out, but really that's not a good term. I think what's happening is that there is been this thyroiditis as well in the background, and now that becomes the long-term, active condition that leads them to hypothyroidism. So about 10% of people with Graves' disease, if you follow them over the long term, they'll end up hypothyroid. Even though you didn't give them radioactive iodine, even though you didn't, they're not on anti-thyroid medications anymore. So that can happen. Can the other happen too, that somebody first presented with Hashimoto's disease and then later in life demonstrates Graves' disease? That can happen too. And there are also situations where Graves' disease just spontaneously remits. That it just kind of just goes away, and it could come back again, but again, it's the immune system that sort of misbehaves and then behaves again. Those are the exceptions to the rule, though. So I think precision medicine is already happening as a treatment for the eye diseases on the threshold of being approved. Is that if I was doing this presentation 30 years ago, this little segment about the IGF-1 receptor would not be on this diagram. Correct me if I'm wrong. It wouldn't be there. But the understanding that the insulin growth factor 1 receptor is involved in the process of the thyroid eye disease has led to a treatment now. We haven't gone to the point to sort of say, okay, could we identify the person in whom this defect or this abnormality is the driving force of the eye disease and only give that person the medication and not just everybody with active thyroid eye disease? That's going to take more time. But this diagram is going to get more and more complicated, and with that is going to come more and more potential targets for individualized therapy. So the answer is yes. We're getting there slowly. Other questions? Okay. Thank you very much for your attention.